Well, good afternoon, everybody. Thank you very much for joining us this afternoon here at the Seat of Perth Library. It's a pleasure to have you here joining us. I'd like to start on behalf of the City of Perth to acknowledge the Whadjuk people of the Noongar Nation, on which the City of Perth and Metropolitan Region is built. We recognise the continued connection to the land, waters and community of this area and pay our respects to elders past, present and future in the spirit of reconciliation. And it's my pleasure to welcome Dr. Andrew Ford and Dr. Dona, who you're going to be hearing more from. Dr. Andrew Ford is a senior lecturer at the University of Western Australia. He's also a consultant psychiatrist of old age at Royal Perth Hospital, where he has a particular interest in cognitive decline, memory problems and dementia. So he'll be talking to you about that. And Dona is a specialist in audiology with a very keen interest in the association between hearing loss and cognitive decline. So she'll be talking to you a little bit about a project that she's coordinating, which is very exciting. So very welcome, and Andrew, welcome.
Thanks, Osvaldo. And thanks to the library for hosting us today, and also a big thanks to Sandra Peterson from the Royal Perth Hospital Research Foundation for making this possible. And thank you everyone for coming. So, the talk's going to be in two parts, as Osvaldo said. I'm going to lead off and talk a little bit about, just generally about memory and aging, what happens as we get older. I'm going to talk a little bit about dementia. So what is it? Why should we be concerned? And then touch a little bit on the causes of hearing loss and age-related hearing loss particularly. And then I'm going to give you a little bit of a snapshot of some of the research that's sort of linking these two conditions, so hearing loss and cognition. And Donna's going to take over. She's going to talk a bit about consequences of hearing loss, so what that sort of may lead to. And then she's going to give a bit of a summary of the research that our collaboration has done to date, and particularly Donna's research, and then talk about the trial, the study that we're currently doing at the moment. And there'll be time afterwards for questions, so we'll try and keep to time. So some of you might be familiar with this graph and this table, but it's really, I've just put it here just to show that we're very lucky. Not only are we living in a nice COVID-safe part of the world, but we're also living in a part of the world where aging is occurring, and that's a good thing. So if you look back, I mean, by the 70s, around 9% of us were over 65. We're looking at around 17, 18%, and if we project through to the next 50 years or so, we're going to be close to a quarter of the population will be over 65. Obviously, with that, it brings a lot more aged people in the community, and that does also bring its challenges. But again, the other good news is if you're born today as a boy, you're likely to live about, on average, 81, 82 years, and as a girl, you're likely to live nearly 85 years. So our longevity is going up. And as we age, one of the things we want to do is age healthily. So there's this concept of healthy aging. Now, it is a good concept, but it's a bit confusing. The definitions, how people define it, and even the terms used are sometimes a bit confusing. So active aging, successful aging, those are all other terms for healthy aging. And the World Health Organization suggests that their proposed definition is the process of developing and maintaining the functional ability that enables well-being in old age. So fairly broad, not specific. Sort of biomedical kind of explanations for healthy aging are absence of disease. But the problem with that is that being free of disease as you get older is not really realistic for most of us. You pick up the odd thing, that's just, it's just the way it is. It's how you live with those diseases or those ailments. And the things that really should be emphasized are about a life participation. And you can see there's a list of things there: life satisfaction, social participation. But cognitive health is emphasized in most definitions. So for most people, when they are asked to say things that they associate with healthy aging, cognition often comes into it. What actually happens though as we get older? Because a common thing we have is changes happen as we get older, and one of the concerns that we have, a lot of people have, is what does this represent? So is this normal, or is this part of something that potentially a pathological process? And look, there are changes that happen. So as we get a bit older, we generally get a little less flexible and sharp. So the ability to problem solve, think on the fly, things like that, remembering things that have just happened, so that's short-term memory, it's often called. But what we do is we compensate and we make up for that because we preserve this thing we sometimes call crystallized intelligence. So our skills, our vocabulary, our knowledge builds up and does not necessarily decay, and this adds to this kind of concept of wisdom. So we develop wisdom. So that the colloquial saying of wisdom in old age is true. That's that accumulated body of knowledge that compensates. And it's important to remember that these changes that happen are normal. Okay, the odd absent-mindedness, forgetting your keys, these things for most of us are a normal process, and they might be related to other things, loss of concentration, feeling a bit stressed, things like that. So the point I want to make here is dementia is not an inevitable consequence of aging. Okay, it is more common as we get older, but it doesn't mean you are going to develop dementia, and that's really important because I think there is a bit of anxiety about it, what's going to happen, and this sense of how do I stop this? And it is important to talk about, but it doesn't mean it's going to definitely happen, that you're definitely going to have dementia, or even cognitive impairment beyond the normal aging process. But so if we look at dementia, major health problem. And just recently it's now become the second leading cause of death in Australia after heart disease. And actually the leading cause of death in women. And so the numbers are, they are concerning. Worldwide, probably approaching around just under 50 million people living with dementia. And in Australia, around 460,000 people living with dementia. And remember those graphs I showed you before? The biggest risk factor for most dementia is aging. So, of course, the more more people over the age of 65 we have in the community, then the numbers of dementia, people with dementia, will grow. So we usually say around 6% of people over 65 will have dementia in the community. But in residential care, so nursing homes, hostels, things like that, it's a higher proportion. But that's dementia. So it's there's the normal, there's age-related memory decline, there's dementia, and then somewhere in between is this concept we call this mild cognitive impairment, where people have cognitive changes that are not just part of aging. Okay, it might be a bit of memory loss, but it's recognizable by that person or someone else. So it's a bit more than just getting a bit distracted. But the important thing is it doesn't impact on their function. Okay, so that they still manage. It's frustrating. Family might be worried, person might be worried, but they're still functioning adequately. And that's just a graph to show about how the numbers of dementia increase as we get older. Okay, so we often talk about around 6% of people over 65 in total, but obviously the older you get, the more you're at risk. So generally talk about the rule of 5, so about 1% of people around 60, 65, and then it doubles every 5 years, the prevalence. So when you're into your sort of late 90s, roughly 40 to 50% of people would be expected to have dementia. Okay. So what is it? It's a syndrome. So a very common question I get, I work in the memory clinic at Royal Perth Hospital, and a common question we get is, what's the difference between Alzheimer's and dementia? I have Alzheimer's, but luckily I don't have dementia. So just to be clear, dementia is a syndrome. So it's a collection of symptoms, cognitive deficits, usually multiple, which impact on your function. So the memory loss, or your ability to recognize things, or your ability to make reasoned judgments, which we call sort of executive function, planning, judgment, be able to coordinate yourself, motor tasks, things like that. They are impaired to the point where they're impacting on your function. So difficulty balancing the checkbook, managing the house, getting lost, maybe putting yourself in risky situations. But that's not all. Dementia affects multiple other areas. affects personality, psychological change, functioning, and this big group of symptoms where I often get involved as an old age psychiatrist, which we call behavioral and psychological symptoms of dementia. But these are the non-cognitive symptoms of dementia. Okay, things like personality change, agitation, aggression, disinhibition, anxiety, depression, and sometimes even psychotic symptoms. So beliefs that might not be based on factual reality. But coming back to dementia, so dementia is the syndrome, and it has a number of causes. And as you can see there, that Alzheimer's disease is still thought to be the most common cause of dementia. And the first four there from left to right, traditionally we would say those four causes, so Alzheimer's, Lewy body dementia, vascular dementia, and frontotemporal dementia, add up to around 90-95% of most cases of dementia, or the cause of most cases. But the reality is what we're seeing now is that this proportion here is much higher. And that a lot of people who have dementia actually have multiple causes for that, not just singular. So not just Alzheimer's disease or not just vascular disease, but a combination of factors, which makes it a bit trickier to treat. I always like to show this slide because it just reminds where the story of Alzheimer's began. And that, is, of course, is Aloysius Alzheimer at the top there. And that was his first patient who he described back in 1901. He was admitted to his hospital. And later he then described the changes in her brain. She went by the name of Auguste D. And that has really sort of been something that has endured over the next 120 years. That there's Alzheimer's in the cause, but it might not be the full story, and it might be that we need to broaden our horizons a little bit in terms of that. Now, I always like to show the students this slide, and I ask them two questions. One, they invariably get right, and the next one they are hopeless at. And the first one is, what do these people have in common? Yeah. And then I ask them, who are they? And there's blank stares everywhere. I know. And when I get to Charles Bronson, I'm always gobsmacked that they don't know who that is. It's a particular childhood hero of mine.
The ex-president.
Yeah. And they're yeah. Yes, Catherine Hepburn at the top. So Hazel Hawke, yeah. And do you know who that is? Perry Como is bottom right, as you're looking, and over there, it's Norman Rockwell, he's a famous American artist. That's Dame Iris Murdoch. So the point is, it's not to illustrate that being autistic is a risk factor for dementia, because it's not, or being an actor, but it's to illustrate that dementia can affect anyone. Okay, it doesn't matter who you are. All right, so the diagnosis of dementia, it's the only reason I put up the slides just to re-emphasize that dementia is, regardless of the type, it's a clinical diagnosis. We make that by interviewing patients, relatives, family, doing some cognitive testing, examination, and sometimes we order fancy scans, but these do not diagnose dementia. It's a clinical diagnosis that then your investigations help to support you. And, for certain types of dementia, we can see certain changes. And, for instance, here in Alzheimer's disease, this area here I'm pointing to is the medial temporal lobes, which are thought to be really important in memory. So they tend to decline as we get older, and we can look for fancy, nice, colourful scans, which show changes up here in this area called the parietal lobe and the frontal lobe, which commonly are underperforming. So this is showing areas that are hypometabolic, so reduced activity. But in the end, it's a diagnosis made clinically, which is good, and it's good for a number of reasons. Obviously, I think it depends. It's important, I think, for help people planning, help provision of services. But the thing that's really the Achilles heel here is we don't have any cures, and we don't have any treatments that can change the disease process. So that's just a diagram of all the different molecules and drugs that are being tested around the world. It's by no means complete, but we still haven't got there. And unfortunately, there's nothing quite on the horizon. So which brings me to, oh, that didn't work very well, to what else should we be focusing on? Obviously, we should be working on focusing people with dementia sufferers and their families and doing all those things. But we should also be looking at risk factors. And we should be looking at things, particularly risk factors that we can do stuff about. So these are what we often call modifiable risk factors. So risk factors that you can potentially make a change. And there's a framework here, because 30, 40 years ago, heart disease, stroke was incredibly high. We've targeted people putting them on cholesterol, looking at diet, managing blood pressure, and over the past 2 or 3 decades, we've decreased the rates of new strokes and heart disease by around 20 to 30%. And a lot of those risk factors overlap. So vascular risk factor is one example of a very significant, potentially significant risk factor for dementia as well, and we can potentially do something about. And there's a number of others, and I won't go through them, but the things that at the bottom here, the protective factors, so things that might be beneficial, but it's hard to be definitive based on current evidence, is being cognitively active, being physically active, active mind, active body, managing your vascular risk factors, being socially engaged, so joining those social groups, being part of an exercise group, being part of a cards group or whatever, something that resonates with you, not something necessary that you just do for the sake of it. Maintaining your mental well-being, your physical well-being, and then possibly looking at your hearing. Okay, and it's a long preamble to the gist of today's talk, but so like dementia, hearing loss is common, particularly as we get older, and the figures there are about, around 40% of people over the age of 65 have age-related hearing loss to varying degrees. Okay, of course, it's a spectrum. But in Australia, we have, roughly 1.5 million of people will have, over the age of 65, if you look at that, will have hearing loss. But many of those many people with hearing loss don't actually get assessed. And Dona's going to talk a bit about the impact of hearing loss, so I won't dwell on that. But the important thing here is that even though you might experience age-related hearing loss, only about 1/3 of people will actually go and get assessed, potentially for correction, so through hearing aids. And the bulk of people will meet hearing aid criteria. I think Dona will probably talk more of that, but sometimes not. But even those that then get fitted with hearing aids, not always great about wearing them. Okay, so only 1/3 will go and seek hearing aids, and then even those 1/3 that get fitted don't necessarily wear them as often as they should. So the main causes of hearing loss as you get older is sort of age-related changes in the eardrum and the small bones. But there are lots of other things that can cause hearing loss. So that's why it's really important to have it assessed by a qualified audiologist. Just simple things like wax blockages, but other diseases, medications. There are a lot of medications that have side effects of hearing loss, and other things can cause it. So it's a fairly complex disease. There's not just one simple cause. And where we've really become interested in is this link between hearing loss and cognitive impairment. So dementia being the one extreme end of that. And the point is, as I said before, both of them are common conditions as we get older. We can't cure. There's no single medication or drug or intervention that will modify the disease course for most people, particularly in Alzheimer's disease. So we need to focus on the risk factors. So hearing loss is a potential risk factor, and it's one that's received quite a lot of attention in recent years. And the thing is that hearing loss can potentially be corrected. So as I said, most people you can correct or improve your hearing through hearing aids. Okay? Sometimes cochlear implants, sometimes simply clearing the wax. But it's something that if that makes a difference, it's important to know. And it makes a difference for other reasons, and Dona's going to talk about that. But in terms of just the connection, the link with dementia, it might have a difference. And whenever you want to try and investigate an association, so is this thing, hearing loss, is it a potential cause or risk factor for dementia, you need to have a bit of a basis by which you think the two are linked. Because there's no point just saying, oh, well, I think this risk factor causes this, but you have nothing to base that on. And there's a few theories. These are the four of the sort of main theories. We don't know for sure. But it might be that you're cognitively declining, you're losing your ability to make sense of the world, you add hearing loss to that, and you become so consumed with having to sort of overcome that you have less cognitive sort of reserve available for the cognitive tasks that you should, that are required. People with hearing loss tend to withdraw, they might drink more, or they might not exercise as much, might be socially isolated, so that might also feed into why that increases the risk of dementia, so shared risk factors. But there is some evidence to suggest that there's a shared biological pathway, and that even that having hearing loss can accelerate brain loss, particularly in areas that are important in Alzheimer's disease. So I'm not going to summarize all the information, but just present a little bit of data and really summary data. So when we're trying to prove if something, a risk factor causes something, a disease, so in this case hearing loss and dementia, we can look at it in a number of ways. The simplest way to start is what we do, observational research. So we observe people, we don't do anything, we don't intervene. And the simplest one there is we just describe a case. Someone with hearing loss and dementia, they had both, seemed to predate the other. But you don't get a lot from that because it's only one person. So we might do a few. But what we often then do is we do something called a cross-sectional type research, where we sample a whole group of people, a cross-sectional sample from the community. And we assess the hearing, we assess their cognition, and we say, well, look, the people who had hearing loss were more likely to have cognitive impairment. Therefore, the two might be linked. We don't know in which direction. Does the cognition cause the hearing loss or the other way around, or is it something else causing it? So we've got an association, but it doesn't mean it's a causal, it's one's causing the other. A slightly better way of looking at it is we take a group of people and we follow them up over time. And we say, okay, you're free of dementia or cognitive impairment, and then we're going to follow you up for the next 10, 20 years. And we're going to look to see those people who developed dementia in that time, were they people who had more hearing loss? So we look at people with hearing loss, we follow them up over time and without hearing loss, and we compare. And we see if the rates of dementia or cognition are higher in the hearing loss group. And we call that a longitudinal prospective type design. Okay, so slightly better, but again, it doesn't give you definitive answers. But there is a lot of evidence suggesting that the two are associated. This is just a systematic review, so it's a collection of studies where we group them together, and then we also take the data from those studies. So one study is great if you find an association, but if you find that association in many studies, then it's a bit more powerful, because those studies are done all around the world in different populations, so it gives you a bit more surety about the association. And so this is just an example of such a study where they've grouped a whole lot of studies together, and they've shown that people who have hearing loss, they are more likely to have cognitive impairment, about twice as more likely, and that if you follow them up over time, and that cohort, longitudinal cohort that I mentioned, then they're also more likely. Okay, but not quite as strong. But it didn't really matter in this study what the type of cognitive change was. So the hearing loss was linked to poorer cognitive performance on multiple tasks, not just memory, things like attention, reasoning, and various remembering facts, things like that. So across the board, that's something called a forest plot. And so all these little markers here on the left of this line suggest that these things are more affected in people with hearing loss. So we've done some studies ourselves. Oswaldo and I did this study from a couple of years ago, where we have a large cohort of volunteers, elderly men, who we've been following up since the mid-90s. And they've been incredibly generous with their time. They keep coming back, and we're still following them up, and they're donating their time. And what we looked at their information back to the 90s, and we looked at those in nearly, over 38,000, nearly 38,000 of them. We followed them up through health records over 10, 11 years on average. And what we found is that the men who had a prior diagnosis of hearing loss, none of them at the baseline, so this is the baseline here, so 100% of them were free of dementia. When we follow them up over time, we found that those with hearing loss, this bottom curve, were about 70% more likely to develop dementia than this group. Yeah, and that's one of the theories about that social isolation and withdrawal and how that increases your risk. But they were diagnosed with dementia through health linkage data, we call it. So again, consistent with the data, but we did the same thing as the other study, but this time looking at studies like ours. So they take a group of people free of dementia, follow them up over time, and seeing if the people with hearing loss in that group are more likely to develop dementia. And you can see our little study at the bottom. And if you look all over, most of these studies are on the right side of the line, which suggests increased risk of dementia with hearing loss. And overall, around 50% increased risk of developing dementia across these 14 studies. So again, this is suggesting that there probably is something in the story. But what we don't know, is it causal? We know there's an association, but it's possible that something else might be explained, like the social isolation, like the vascular. And for most of these kind of studies, we try what we call control for that statistically. So we include their cardiac disease. So in our study, we include things like heart disease, cancer, and a few other things to see if those better explained. And we found, like most of these studies, that despite that adjustment for those other risk factors, the relationship still held, that there was an association. And just that meta-analysis that I presented our data, and if that just is the few studies where the assessment of hearing loss and dementia was more rigorous, so we call them better quality studies. But if you can see here, in these good quality studies, individuals were about 3 times more likely to develop dementia if they had hearing loss. And this is consistent with what's been coming out in the Lancet over the last few years. So some of you might have seen this graph, which is a very pretty, colourful graph, or diagram, should I say. But basically, there was a publication in 2017, and then an update now this year. And the only thing I want you to concentrate on is this. So the suggestion by the authors is that around 40% of dementia can be attributable to modifiable risk factors. So theoretically, if you got rid of all 12 of those risk factors, you would reduce the rates of dementia by 40%. And hearing loss was thought to be the biggest contributor, 8%. So if we could eradicate hearing loss, obviously it's not possible to completely eradicate a risk factor, but we could reduce dementia cases by 8%. All right, so I'm going to finish up. So age-related hearing loss is common and can be potentially corrected through fitting hearing aids. Dementia and cognitive impairment are also very common, but can't be cured. Okay, we can do things to manage, we can do things to assist, but we can't ultimately fix the problem as yet. There's a lot of evidence to suggest that the two are linked from observational data. And as I said before, we've got a framework. We have reduced conditions by focusing on risk factors. So what we need to try to find out is, could the correction of age-related hearing loss through fitting hearing aids, through correcting that hearing loss, can it benefit us? Can it benefit our cognition, our mood, general quality of life? Now I'll hand over to Dona.
Thank you, Andrew. Thank you all for coming here today. So I'm going to talk to you all about one of our current research projects known as the HearCog trial. So before I start my presentation, I'd like to express my sincere gratitude to all our research participants, our research team, our collaborators and funders. Without their support, none of this would have been possible. So thank you. So I'm going to talk about the consequences of having an age-related hearing loss. So currently, 1 in 6 Australians do have a disabling hearing loss, and by 2050, 1 in 4 Australians will have a hearing loss. That is very concerning. So what happens when we have a hearing loss? So how many of you here struggle understanding speech in noisy situations? So what do? Do you go to noisy situations? Do you go to restaurants and pubs and, because you can have a conversation, or do you try to avoid noisy situations? Avoid them, right? So as a result, and if we can't have a meaningful conversation with our loved ones, family and friends, even if we are surrounded by a lot of people, if our communication is affected, then we try to avoid these situations. As a result, we feel lonely emotionally and socially lonely. So one of the consequences of hearing loss is social isolation and loneliness. And we also found that untreated hearing loss is also associated with mental ill health symptoms. I'm going to talk about them in a little while. We also found that, as Andrew mentioned, untreated hearing loss is also associated with cognitive impairment and dementia. So what is social isolation? It simply refers to limited network and social contacts. So as we age, we rely a lot more on quality of our relationships, not the quantity. So the loneliness is the unpleasant feeling we get when there is a gap between desired and existing level of relationships. And loneliness is a risk factor for depressive symptoms, reduced physical activity, cognitive impairment, and dementia. Both social isolation and loneliness are risk factors for increased mortality as well. So we wanted to find out the association between untreated hearing loss, loneliness, and social isolation. So we recruited about 202 volunteers, and we asked them to complete a set of questionnaires. So what did we find? So regardless of the level of the hearing, all of our participants had a lot of good social support. However, social interaction was affected. So there was an interaction between aging and hearing loss. So poor social interaction scores were seen for people who were not only older but with poor hearing. Living alone, having depressive symptoms, and stress were related with being socially lonely. We also found that hearing loss was associated with emotional loneliness. That meant as the severity of the hearing loss increased, the level of emotional loneliness also increased. Then we wanted to find out what happens between hearing loss and mental ill health symptoms such as depression, anxiety, and stress. So I worked with Professor Almeida on this paper. We recruited 151 volunteers from around WA, and we also asked them to complete a set of questionnaires and also a hearing test. We found that hearing loss was associated with depression, anxiety, and stress. And again, as the level of hearing increased, the old adults also started experiencing increasing levels of depression, anxiety, and stress symptoms. So then we asked the question, then what about the cognition and memory and thinking skills? So then when we first started this project, we went and had a look at all the cognitive screening tools. And then we realized all of the tools required you to listen to a set of instructions, understand the instructions, and perform a task. The problem here was that if you have a hearing problem, you don't really hear the instructions, you don't really understand what you have to do, and you do something else. And then the people with hearing impairment were most of the time misdiagnosed having memory problems. So we wanted to eliminate that in our study. So we decided to use a test of non-verbal cognitive test battery. So we asked our participants to complete a hearing assessment, cognitive assessment, and a questionnaire on depression, anxiety, and stress. So here's an example for a non-verbal cognitive test battery that we use in our study. It is similar to a set of games you play on a computer screen, and each game has measures a different cognitive function. So what did we find? Again, as Andrew mentioned before, we found that untreated hearing loss was associated with number of cognitive functions. And as the level of the hearing loss increased, we saw impairment in memory functions such as episodic memory and working memory. So as an audiologist, it is very common for us to wonder, so what happens if we treat the hearing loss? What will happen to the cognitive functions? So we decided to design two pilot studies for that. So there are many ways of treating hearing loss. So if someone has a mild to moderately severe hearing problem, they benefit from using hearing aids. For those who have moderately severe to profound hearing loss, they benefit from a cochlear implant. So cochlear implantation is a surgical procedure in which set of electrodes are placed in the inner part of the ear, and the signals are sent to the brain via the hearing nerve. So for this study, we recruited group of people who use a cochlear implant and group of people who are waiting to receive a cochlear implant. We asked them to complete a hearing, cognition, and psychological test. And this is what we found. So we found that after using a cochlear implant for a period of 1 year, we found a significant improvement in understanding speech. We also found an improvement in number of cognitive function tasks such as episodic memory, reaction time, and working memory compared to those who were waiting to receive a cochlear implant. Then we wondered, what about the hearing aids? So to answer that question, we recruited 52 participants who had a hearing loss but who were not interested in using hearing aids. We also recruited 38 hearing aid users. Again, they completed hearing test, speech understanding test, cognitive assessment test, and mental health assessments. So we found after using a hearing aid for a period of 1 year, hearing aid users performed better in attention and working memory tasks. So after gathering all the information, then we thought, okay, we need to do a randomized control trial. In research, randomized control trials are similar to a gold standard, and we get very high quality evidence. So we put all the information we gathered over the past few years and designed this study. We called it HEAR-COG trial, hearing and cognition, so HEAR-COG trial. So the aim of this study is to find out, by treating hearing loss using hearing aids, whether we can delay or arrest the cognitive decline or risk of developing dementia. We also wanted to find out whether hearing aids have an impact on memory and executive functions, mental health symptoms, quality of life, physical health, and health-related costs over a period of 24 months. So we invite older adults who are 70 years and older who think they have a hearing problem to take part in our research study. So once we have recruited them, we ask them to complete a simple screening test, which takes about 1 hour. It has a hearing screening component and a memory screening. So based on the results we get from the screening, if they meet the study criteria, we invite them to take part in the study. So we randomly divide these participants into 2 groups. One group would receive a pair of hearing aids immediately, and the other group have to wait for a year to receive a pair of hearing aids. So all participants of this study here in this study receive free Oticon OPN1S behind the ear hearing aids. They have very advanced technology and help understand speech, in noisy situations and also have access to sound coming from 360 degrees. So we expect all our participants to complete set of assessments every 6 months over a period of 24 months. So we measure their global cognitive abilities and the nonverbal cognitive assessments like I showed you in the previous slide. We also measure their health status, physical function, depression and anxiety symptoms, daily living functions, social support, and we also measure whether they get any benefit from the hearing aids. So during the hearing aid assessment part, we conduct a full hearing assessment, and we also discuss about the daily communication needs of each participant. So communication needs can differ from one person to another. Then we do the hearing aid fitting, and we use a computer program and program the hearing aids to fit the hearing loss as well as the communication needs of each participant, and then we follow them up in about 2 weeks just to make sure they are doing well, and then we follow them up every year. Participants of our study also have an option to take part in 2 types of imaging. First one is MRI scan, that's magnetic resonance imaging. So hearing loss is associated with changes in the brain, such as reduced cerebral volume and the changes in the central auditory white matter tracts. So we also seen that those who have a hearing loss also experience accelerated brain volume loss compared to those with normal hearing. So in this part of the study, we first find out the changes that are associated with brain changes that are associated with the hearing loss. And then we try to find out by treating hearing loss using hearing aids, whether we can see any more changes, whether we can reverse the changes that we observed before. Second imaging technique we use in this study, FDG PET. So it is cerebral glucose metabolism and the brain function. In this, when someone has a hearing loss and there are characteristic patterns of metabolic activities in the brain, we measure that through this type of scan. And again, we see what happens after we treat the hearing loss. Both hearing loss and dementia have a significant impact on Australian economy. And so by treating the hearing loss, if we can delay or arrest cognitive decline and dementia, that would help improve the quality of life of older adults and also help reduce the costs that are associated with health services and social support services. So in this part of the study, that's what we are planning to evaluate. So we access the data from the Department of Health data linked system. We get the information regarding pharmaceutical and Medicare-based costs and other costs associated with emergency and home and community care and things like that. So, and then with the analysis, we try to find out about the cost effectiveness of this study. With that, I have come to the end of my presentation. This study would not have been possible without the support we got from Oticon, WA Department of Health Research Translation Project Grant, Rebecca Cooper Foundation Grant, and Royal Perth Hospital Impact and Innovation Grant. So we would like to thank all our funders and thank you all for listening. If you are interested in taking part in our study, please get in touch with us. We would like to invite you for a screening assessment. Thank you.
Thank you.